Tanya. Very good morning to all. Today I am going to present a protocol presentation. Myself, Srinivasan, from psychiatric social worker here. My protocol title is a study on internal addiction among families of psychiatric in and outpatients in psychiatric department. My principal investigator, Dr. Shobhit Garg sir, Professor HOD, co-investigator, Dr. Vinay Tejan, senior resident, and co-investigator myself.
You will be principal investigator.
Sir?
You will be the principal investigator.
Okay, sir. Sure. Objective is to understand socio-demographic parameters.
You can comment. You are just this is a class of which kind of study it is? Kind of study.
So it is like a.
You have to write it. Protocol presentation में जो corrections बताएंगे, you have to write it.
Okay, sir.
Writing of information. What kind of study it is?
Sir, it is like a distributive design, sir. Distributive research design, and cross-sectional design, sir.
Study है cross-sectional.
Sir, it is a first study in India. Cross-sectional.
Is it a cross-sectional?
Cross-sectional. Objective is to understand the socio-demographic parameters among the patients, to assess the internal addiction among the in and out patients, and to understand the internal addiction level among family members of both in and out patients. Sir, if
you say in and out patient, whereby one mental patients or psychiatric patients.
Okay, sir.
Then the methodology you explain.
Sure.
Status में भी लिख दो.
Okay, sir.
You know that in our patient, just write psychiatric patients. What are you doing? Don't remove now.
Okay, sir. Okay,
Read it later on.
Sure, sir. Methodology, the study will plan to assess the internal addiction among psychiatric patients, family members. Research venue, our hospital. Cross-sectional type of research method will be used in this study. Patients will be recruited after fulfilling inclusion and exclusion criteria. Information and purpose of the study will be explained in detail to the family members. And the other family members will be assessed by as per telemedicine practice guidelines in India, 25th March 2020. Written informed consent taken from the patient and the family members who is brought to the patient in our hospital. Duration of this project is 6 months. Inclusion criteria: children, adolescents, adults, and parents, and geriatric seniors also. Okay, sir. Old age. Old age.
Elderly.
Okay, sir.
Elderly population. Elderly population. Elderly
if anybody in the family, those who are using more than 1 year mobile phone by Android or any kind of mobile phone, they will be included in our study. Children will be called like below 18 years and adults. After 18 years will be called as adults and old age.
Sure. Till 18 years they have children. Taken it from somewhere.
Yes, sir.
Childhood and adolescent population. Why you writing 0?
Okay, sir. Okay,
Why you
sir.
writing 0?
So below 18 years, sir.
When you're saying that 1 year mobile usage, you expect 0. You're not supposed to write this.
Okay,
This
sir.
is scientific terminology.
Okay, sir.
Right? Why you writing? Everyone knows China had also is till 18 or below 18. And then adult population, and then what about the geriatric population? Prove that point.
Okay, sir.
So you're just saying that any patient or the accompanying family member who is using mobile phone for more than a year.
Okay, sir. Sure. Psychiatric patients, all the disorder diagnosed as per ICD-11 included in the study. Exclusion criteria: who is not interested to participate in the study, who is not willing to share family members' details in the study.
How many family members do you want per patient?
Sir, as per genogram,
All.
yes, sir.
Why?
Sir, I want to do family diet in study, sir.
So you said family diet. Nowhere till now family diet is. What do you mean by diet?
Sir, family procreation, and I want to do take sampling like family procreation and family type of orientation, sir. All the family members.
What is procreation? What is orientation? Explain me.
If anybody married and they will be separated, it is called as family of procreation. And family of orientation, three type of generation, like Dada Dadi, Nana Nani, and father ki bhai bagan, mother ki bhai bagan.
What do you mean by diet?
Sir, including all the family members, like family of orientation.
But diet means to know.
Yes, sir.
What do you exactly mean by diet? Diets. How you create those diets?
So all the family members, including all the family members.
So you're saying all the living family members,
Yes, sir.
you will assess
Yes, sir.
them for more than 1 year of mobile usage.
Yes, sir.
You make a genogram and you will assess all of them,
Yes, sir.
whomsoever are using.
Yes, sir.
So वो clearly लिखना है.
Okay, sir. Procedure: family of procreation and orientation will be included in the study. Other family members will be assessed over phone call, and call will be recorded as per telemedicine guidelines in India. And primary support caregivers is not willing to participate in the study would be included as a dropout.
Call will be recorded, right? Details will be recorded.
Okay, sir.
Call will be recorded means that you are recording their calls.
Yes, sir. Okay, sir.
But are you sure that if there are 10 people,
Yes, sir.
if there are 10 people in the genogram, 10 family members, all of them has to participate. Otherwise, it takes.
No, sir. First of all, we need primary caregivers, sir. Like those who are living with the patient in the family, whether separated family, extended
How
family.
many? You're saying that dropout will be counted.
Yes, sir.
So where you will count the dropout? Primarily supported caregivers. How you define those primarily supported caregivers?
सर पेशेंट अगर सेपरेटेड फैमिली है, न्यूक्लियर फैमिली है, एक्सटेंडेड फैमिली है, उनके साथ कौन कौन रहता है हमको पूरा चाहिए सर. अगर कोई भी पार्टिसिपेट नहीं करेगा उसको ड्रॉपआउट में काट लेते हैं.
Patients who are living, caregivers who are living with the patient.
यस सर.
I think उसको थोड़ा clearly define. ना supported caregivers who are residing with the patient. उनको हम ले.
ओके सर.
These still are not clear.
ओके सर.
You are saying procreation, you are saying orientation,
यस सर.
and then now you are saying primary caregivers नहीं होंगे तो dropout. What do you exactly mean by that? Methodology में you have to be very clear now.
Yes, sir. Yes, sir. Sir, first of all, we need.
Supposedly I come, my family, 3 people. Okay.
Yes, sir.
And my extended family, there are people in Mathura, there are people in Punjab, there are people in Hardwar, all sorts of places.
So I will.
How you will go?
So I will take phone numbers from the patients and the family. Then we will call afterwards, sir.
All the.
Yes, sir.
But then when you will consider them as a dropout? Those extended family members.
कोई कंसर्न नहीं दे पा रहा है सर.
कोई भी.
Yes, sir.
कितने भी अगर मान लो जीनोग्राम में 15 लोग हैं, 15 में से अगर एक ने भी कंसर्न नहीं किया, you consider as a dropout.
Yes, sir.
उसको clearly लिखो.
Okay, sir.
Then it doesn't become primarily supported caregivers.
Okay, sir.
It will be any caregiver in the genogram.
Okay, sir.
Not willing to give
Consent?
No, I'm not saying. Don't say okay to me.
Okay, sir.
Whether you are comfortable with that kind of a design.
Yes, sir. Yes, sir. Actually,
Do you mean that, or do you mean that only primarily supported caregivers are not supposed to participate?
उदाहरण सर पेशेंट के साथ अभी करंट कौन कौन रखता है, उधर नंबर ऑफ लिविंग मेंबर्स लाइक 4 मेंबर्स है, 5 मेंबर्स है, उनमें कोई कंसर्न नहीं दे पाए तो वो ड्रॉप आउट करेंगे सर, ऐसे सोचेंगे.
4 या 5 उसमें से एक भी नहीं देगा तो ड्रॉप आउट करेंगे.
यस सर.
You clear this issue. अभी तो you were saying yes to extended family members.
So इसलिए मैं प्राइमरी सपोर्टर कैरियर्स लिखा सर. अभी पेशेंट के
You were
साथ
saying yes to extended family. Yeah, I'm not getting the point.
यस सर. एक्सटेंडेड फैमिली से बाहर रखता है सर, लेकिन उनको मैं आप बाद में करेंगे ना सर. अभी पेशेंट के साथ कौन रखता है सर, उसको हम बहुत जरूरी लेना है सर.
Simple thing is when you will consider a family as a dropout.
अभी नंबर ऑफ फैमिली मेंबर्स हम ले रहे हैं ना सर, पेशेंट के साथ कौन रखता है, उसमें एक भी नहीं दे पाए तो ड्रॉप आउट में काफी करेंगे.
Or okay, and if they will give you the details,
Yes, sir. काफी
and except to बाकी family members जो नहीं रहते हैं साथ में,
उसको भी हम ऐड करेंगे सर, लेकिन उसमें ड्रॉप आउट इंक्लूड नहीं करेंगे.
ये clearly लिखो.
ओके सर. Society of data will be assessed by Kupusabi modified version. For children, ECS like USV scale 10 items developed by Kwon et al. It is a Korean study scale. Korean scale, and for adults, internet addiction scale by Young will be assessed for all the persons.
So are they validating the population?
Yes, sir.
So you can validate scale
Yes, sir.
as these scales captured in the population.
Yes, sir. Yes, sir. पहले study में publish reference में sir.
Yes.
Sir, this study में use किया सर, 2-3 study में use किया सर, Indian study.
Are they adapting to our population?
No sir, translator को करना है सब scale को करना पड़ेगा.
So
Yes, sir. These are my references, sir. Translation study.
So what you will contribute to research with this case?
Sir, it's the first type of study, sir. Family members, मतलब like a cluster of family studies, sir. Internet edition, because everybody using internet nowadays, sir. So in psychiatric department, sir, इसको parents को किया है sir, लेकिन family members को नहीं किया sir, पूरा family.
Among adolescents, children of parents with mental illness.
Yes, sir.
Parents have mental illness. Patients के बच्चों को तो किया है.
सर कोई तो सिबलिंग्स को किया सर, कोई तो पेरेंट्स को किया था स्टडी, लेकिन पूरा फैमिली मेंबर्स को कोई भी स्टडी नहीं किया.
What scale did you use?
Here, sir, internet addiction test, sir. 40 items, sir. So we cannot. So scales ज़्यादा है, questions ज़्यादा है, sir. 40 items. We cannot assess over phone, sir.
That scale has to be Indian population.
Yes, sir. Indian population, लेकिन translate करना पड़ेगा, sir.
कौन सी स्टडी ने यूज किया है?
सर एक और स्टडी में देखा सर, लेकिन वो ओरिया लैंग्वेज में यूज किया सर, लेकिन हम हिंदी में ट्रांसलेट करना पड़ेगा.
Google Translate.
सर सर्टिफाइड ट्रांसलेटर सर.
Where you get certified? There are guidelines where any one of your friend can do it.
Okay, sir.
You have to actually translate in Hindi.
Okay, sir.
Then back translate in English, and then reverse translate. The preferably by 2 people separately. Okay, then they are conforming, then it becomes a valid translation.
Okay, sir.
See guidelines है वो आपको से भेजिएगा.
Okay, sir.
Still, you have to write the protocol. What are we defining? What help it will give us? It will give us in knowing this phenomena more better. Intervention-based models हम बना सकते हैं, बना सकते हैं.
Okay, sir. Methodology read करेंगे.
Then methodology में क्या चीज़ चाहिए होता है? Population.
Yes.
We are having to clearly define क्या one patient population जिसका family होगा, सारा जीनोग्राम बनेगा, उस family के जो primary support caregivers हैं, उनको सबको involve किया जाएगा, otherwise they'll be considered as a dropout. The other family members information will act as an assisted information.
Okay, sir.
And how you create those dyads, which is very, very important.
Okay, sir.
Okay.
Sure.
It's a cross-sectional system, single system.
Okay, sir. Thank you, sir.
Okay, thank you. ये सब करेक्ट करके लिख के सबमिट कर दो.
Good morning. The topic for today's presentation is cluster A personality disorders. Moderator is Dr. Sanjeev Ma'am and presented by Dr. Tanu. Well, now we'll define what is personality. Personality is defined by Alport as a dynamic organization of the psychobiological systems by which a person shapes and adapts in a unique way to a changing internal and external environment. Now, personality disorders. The symptoms of personality disorders are egosyntonic, means they're acceptable to the ego, and alloplastic, means they adapt by trying to alter the external environment rather than themselves. Personality disorders are enduring, persistent, and pervasive disorders of inner experience and behavior that causes distress or significant impairment in the social functioning as per DSM-5. Persons suffering from personality disorders have long-standing behavioral traits that are pervasive and apparent in a wide range of social and personal contexts. Now, first is the paranoid personality disorder. They have a long-standing suspiciousness and mistrust of a person. They refuse responsibility for their feelings and assign responsibility to others. They are often hostile and irritable and angry. The hallmark features of paranoid personality disorders is the tendency to interpret actions of others as deliberate, demeaning, and threatening. Pathological jealousy is the hallmark of this disorder. Question of fidelity of spouse and sexual partner is always present. As per DSM-5, pervasive distress and suspiciousness beginning by adulthood indicated by 4 or more of the following should be present for the diagnosis of paranoid personality disorder. First is suspects without sufficient basis that others are exploiting or harming him or her. Doubts others' loyalty, reads hidden threatening, demeaning, and benign events, persistently bearing grudges, is reluctant to confide in others, perceives the attacks on his or her character that are not apparent to others, react angrily, has recurrent suspicions. The same 7 criteria are present in the ICD-10 with excessive sensitiveness to setbacks and rebuffs, tendency to bear grudges persistently, suspiciousness, combative and tentaneous sense of personal rights, recurrent suspicions, tendency to experience excessive self-importance and manifest in a persistent self-referential attitude, and out of these, at least 3 should be present for the diagnosis of paranoid personality disorder. Now, the epidemiology. The prevalence of paranoid personality disorder is 0.5 to 4.4% in general population and 10 to 30% in psychiatric inpatients. They are more common in men than in women, and occupational marital problems are most common in this disorder. Comorbidity is increased risk of major depression, obsessive compulsive disorder, agoraphobia, and substance abuse or dependence. Postulated to be pre-morbid antecedent of delusional disorder and paranoid type. Familial pattern and genetics, increased risk among relatives of probands with chronic schizophrenia and delusional disorder, paranoid type. Now, the differential diagnosis includes delusional disorder, paranoid schizophrenia, borderline personality disorder, major depressive disorder, and substance use disorder. Now, the schizoid personality disorder, it is characterized by lifelong pattern of social withdrawal. They are eccentric, isolated, or lonely. They have a discomfort with human interaction, and they have a blunt or constricted affect. As per DSM-5, a persistent, pervasive pattern of detachment from social relationships and restricted range of emotions in interpersonal settings beginning in the early adulthood, indicated by four or more of the following should be present. Neither desires nor enjoys close relationships, always chooses solitary activities, has little interest in sexual experiences, takes pleasure in few activities, lack close friends, indifferent to praise or criticism, shows emotional coldness or detachment. In ICD-10, difficulty experiencing pleasure, difficulty expressing emotions, apparent indifference to criticism or praise, has little interest in sexual experiences, takes pleasure in few activities, and shows emotional coldness and detachment. Out of these, at least 3 should be present for the diagnosis of schizoid personality disorder. Now, the epidemiology. The prevalence is about 3.1 to 4.9% of the general population. It is more common in male with a 2:1 ratio. Solitary interest and success at non-competitive, lonely jobs that others find difficult to tolerate. Lifelong inability to express anger directly. Familial pattern and genetics, increased prevalence among relatives of probands with schizophrenia or schizotypal personality disorder are present. Now, the differential diagnosis: schizophrenia, delusional disorder, affective disorder with psychotic features. Course and prognosis: it occurs in early childhood and adolescence, and it is long lasting. Schizotypal personality disorder: they are odd, strange, even to a layperson. Magical thinking, peculiar notion, ideas of reference are generally present. They also have illusions and derealization phenomena. As per DSM-5, pervasive pattern of social and interpersonal deficit marked by acute discomfort with close relationships as well as cognitive or perceptual distortions or eccentricities of behavior beginning in early adulthood is indicated by 5 or more of the following, with ideas of reference, odd beliefs and magical thinking that influences behavior and inconsistent with subcultural norms, unusual perceptual experiences, odd thinking or speech, suspiciousness or paranoid ideation, behavior and appearance that is odd and eccentric, lack of close friends, excessive social anxiety that does not diminish with the familiarity and tends to be associated with paranoid fears. In ICD-10, it includes schizotypal syndrome among the psychotic disorders and is not as a personality disorder based on the biological affinities of schizotypal individuals with schizophrenic patients. Now, the epidemiology. Prevalence is 3.9 to 4.6% in general population. It is frequently diagnosed in females with Fragile X syndrome, but in DSM-5, it is more common in males. Greater association biological relatives of patients with schizophrenia and higher incidence in monozygotic twins has been noticed. Comorbidity: more than half of these patients have had at least one episode of major depression and has 30 to 50% of major depression concurrent with this personality disorder. 10% of schizotypal personality disorder eventually committed suicide as per Thomas McLeish, and can be distinguished from schizoid and avoidant personality disorders by the presence of oddities in their behavior, thinking, perception, and communication. If psychotic symptoms appear, they are brief and they are fragmentary. Differential diagnosis includes schizophrenia, delusional disorder, and affective disorder with psychotic features. Now, the course and prognosis. The schizotypy is a pre-morbid personality of the patient with schizophrenia. There are occupational and social difficulties. Some may maintain a stable schizotypal personality throughout their lives normally. Now, the management. Individuals with personality disorders do not usually seek treatment owing to the lack of insight. The approach is to gain patients' confidence by avoiding early confrontation. Psychotherapy is the primary treatment of choice, and pharmacotherapy is useful in dealing with the agitation and anxiety. In most cases, anti-anxiety agents such as diazepam suffices. Haloperidol or low-dose antipsychotics to maintain severe agitation or delusional thinking is used. Now, as per ICD-11, ICD-11 defined personality by problems and functioning of aspects of self and interpersonal dysfunction that have persisted over an extended period of time. Now, in ICD-11, they have divided personality disorders in mild, moderate, and severe personality disorders. In mild personality disorders, some areas of personality functioning are affected and they are not associated with self-harm or harm to others. In moderate personality disorders, multiple areas of personality functioning are affected and is usually associated with self-harm or harm to others. In severe personality disorders, severe disturbance often associated with harm to self or impairment in all or nearly all areas of life like personal, family, social, and occupational. This is combined with the prominent personality traits that contribute to the personality disturbance trait domain. It is continuous with normal personality characteristic and corresponds to the underlying structure of the personality. They include negative affectivity in personality disorder or personality difficulty. There is detachment in personality disorder or personality difficulty, dissociality, disinhibition, and encastic and borderline pattern. So they have removed all these clusters from ICD-11. Right. So defense mechanism, Wilhelm Reich coined the term character armor, person's characteristic defensive styles for protecting themselves from internal impulses and interpersonal anxiety. Broad influence on contemporary context of personality and personality disorders. Each personality disorder have a cluster of defenses that help psychodynamic clinicians to recognize the character pathology present. In paranoid personality disorder, projection is used as a defense mechanism, and in schizoid personality disorder, introjection and fantasy is used as a defense mechanism. In projection, this is an immature defense mechanism attributing one's own unacknowledged feelings to others to prevent rejection of intimacy through suspiciousness. Introjection of a loved object involves internalization of characteristics of the object with the goal of ensuring closeness to and constant pressure to the object. Introjection of a feared object serves to avoid anxiety through internalizing the aggressive characteristic of the object. In fantasy, tendency to use fantasy and to indulge in autistic retreat for the purpose of conflict resolution and gratification is present. These are my references.
Any questions? Strategy, anything which you find it difficult? Steers? Schizoid, paranoid, schizoid. We're looking at 3% disorders. Shared visual description possibilities. What is a personality disorder supposed to be in various criteria like prevalent population in patients who are admitted. So we would expect the patients who are getting admitted, they will have personality traits, at least at trait level or disorder level that needs to be teased out. Many patients you will see not able to make any meaning out of the presentations. Own cognitive discomfort, they are saying it is bipolar, they are saying it is schizophrenia, but they are not so simple so that we categorize them. So they actually have these personality issues which lead us to a lot of confusion. So Dr. Tanya, if a patient comes with paranoid personality and 4 to 5 weeks of psychotic intervention, and then patient gets what you say? how you conceptualize. Already having paranoid personality at a very brief period of complete breakage over reality. It has completely become diluted. So, but only for 4-5 days. You can expect the same nothing we again. So, what do you feel? What has happened to the patient? A brief psychotic reaction. What do you call that? Context of personality. These are micropsychotic episodes. So very, very common. Many times they get attributed to us with micropsychotic episodes. We call it acute and transient psychotic disorder. And very common in borderline personalities. Very common in the clusters also.
So but it was written that micropsychotic episodes occur for 4 minutes to hours. So it is possible.
Not more than 7 days. Till 7 days you can extend it. Usually it is for hours, days, not more than 7 days. उससे ज़्यादा होगा तो then you need to see other person.
Personalities can be changed.
Sorry. What do you mean the question means? Personality change हो सकती है. Personality 18 साल में personality has been made. Our understanding person is carrying the personality attributes now. Maybe what we feel at times is a paranoid personality traits. The next time he gets admitted, says no sir, schizotype. Third time he gets admitted, he feel no, this all was broken. This is schizophrenia. Our understanding would change. The personality is formed. Trait will never change. Say state versus trait. State is those episodes of disease. The trait is that your disposition, personalities will never change. Your states will change. Our understanding might change. Our evaluation might change. That is why evaluation becomes very, very important. And we're seeing so many elderly patients. Many of them have pre-COVID, 60, 65, they go into these behavioral issues. They have a lot of anxiety, some of them have paranoia. I still remember a case, paranoid personality presenting with late onset anxiety, appearing to us, as if she's having psychosis. But it was not the case. We did into it, antipsychotics was worsening her, anti-anxiety she responded. Because actually the paranoid personality anxiety is over paranoia. It's actually not psychosis. Or treat कैसे करते हैं any personality symptomatic. Any personality issue with anxiety, you will get aggression, you will anti-aggressive. How to differentiate them? Cluster A with social anxiety, cluster A with autism.
So in cluster A personality anxiety, the fear is of not of humiliation, but it is a fear of paranoia. But in social anxiety, the main feature for anxiety is humiliation, which is
so 22-year-old student, English student, come to me, the parents, he said for last 3 years, he doesn't prefer moving out of this house. He says that people judge me. So what is your take on it?
People judge me because of what?
People judge me because of what? So people judge me, so I don't go out. So whether it is part of paranoia, cluster A, or a social anxiety, some form of
Social.
Actually, someone having schizoid versus social anxiety, how you'll differentiate? Social anxiety, when you say I'll be judged, patients would say that I'll be evaluated, people will judge my expressions. कैसे करेंगे? चलेंगे